Congratulations to the organizing committee. And it's my honor to introduce Professor Dr. Rodina Sobhy that tell us about the exercise testing in pediatric arrhythmia.
Okay. Hi again. I hope my lecture won't be too much. Okay, so I'm talking about the exercise ECG testing in pediatric arrhythmias. My agenda. Exercise testing has vast applications. However, I'm going to focus on the exercise testing in children, mainly focusing on their value in arrhythmia. Exercise test is a valuable tool for diagnosis and management of pediatric arrhythmias. Variable arrhythmias can be maybe induced or abolished by exercise. We've talked about this through the presentations. It also helps to assess how the cardiovascular system responds to physical stress. Okay, so the role of exercise testing in pediatric arrhythmias, identifying what are the exercise-induced arrhythmias, like mainly ventricular arrhythmias or less commonly supraventricular arrhythmias. As I said, exercise can trigger arrhythmias which are otherwise absent during rest. To evaluate also, an important thing is to evaluate the heart rate response to exercise, or as we say, the chronotropic competence, and to correlate symptoms with ECG findings. Exercise testing can be helpful in provoking arrhythmias, uncovering potentially diagnostic ECG abnormalities, and assessing a response to therapy. As for the indications, the coronary artery disease is rare in children, which is the commonly thing in adults. Indications for exercise testing in children are more broad, okay, including in patients with known arrhythmia for evaluation to assess if this arrhythmia is abolished or induced by exercise. Patients with familial history of certain cardiac death for their risk assessment, as the CPVT, the catecholaminergic polymorphic ventricular tachycardia, long QT, Brugada syndrome. In patients with syncope and dizziness, and for post-treatment monitoring after a cath ablation or pacemaker implantation to assess their effectiveness. For example, they are recommended as class 1 for the patients, the family members to be evaluated of SADS decedents, recommended for the first degree relatives. This is the EC guidelines. Ventricular arrhythmias, the role in the ventricular arrhythmias, premature ventricular contraction are the most commonly encountered arrhythmias during exercise. As we said, if a patient has PVCs or ventricular arrhythmias, they may be abolished. Or if we have PVCs during an exercise test, should raise a concern in patients with a history of cardiomyopathy, valvular heart disease, myocardial ischemia, or with a family history of sudden cardiac death, especially if they are triggered on low levels of exercise, if they are multifocal, or associated with concomitant ST segment abnormalities. As for the VT, exercise-induced VT is highly suggestive of an underlying heart disease. Exercise can induce the CPVT or VT from the RVOT origin. In CPVT, you can see the pattern, the bidirectional PVCs. Okay, and it's a very important, reliable method to establish diagnosis, exercise testing. Long QT, and we monitor the response of prolongation of the corrected QT interval to exercise. Response to beta blocker therapy can be assessed. However, should be very cautious because tachycardia can be induced, the VT can be induced during the exercise. Supraventricular tachycardia, generally we don't use exercise testing. It's of limited utility in patients with SVT because they occur less commonly during exercise. However, in WPW syndrome, patients with children with manifest Wolff-Parkinson-White pattern, if we exercise them and the accessory or the pre-excitation disappears, this is probably a low risk accessory pathway because with a long refractory period. For example, this patient has undergone exercise and the 2 ECGs on the upper one, the lower one, it disappeared, pre-excitation. It's also can be used in young athletes who have symptoms, may experience symptoms during competition, like syncope, chest pain, or dizziness. Although these symptoms may indicate the presence of a serious underlying cardiac abnormalities like hypertrophic cardiomyopathy, ARVD, anomalous origin of the coronary artery, or other ventricular arrhythmias. However, sometimes they can just be benign conditions, for example, dehydration or hyperthermia. And exercise testing can be helpful in differentiating the etiology of these symptoms. We can use it in conduction system disturbances to determine the maximum achievable heart rate during exercise. For example, children with congenital complete heart block, their ventricular rate response to exercise may guide on the timing of pacemaker. Actually, we rarely use it. However, we can use it to relate the symptoms of the patient and know his chronotropic competence, especially patients with, for example, sinus node disease. However, we must know that such patient may have, their heart rate may not increase. On the contrary, they may be at risk of syncope or decompensation, so we should be aware of this and taking care to prevent the injury. AV blocks that results from high vagal tone, they disappear during exercise. Complete heart block induced by exercise is uncommon and may be the result of sinus node ischemia. And if this happen or starts to happen, you should stop immediately the exercise testing. As I said, it's heart rate response to exercise may be important in children who demonstrate chronotropic incompetence after certain types of surgery. As well, the cardiopulmonary functional capacity testing is we can use a gas analyzer during the exercise ECG to analyze the oxygen consumption and know the functional capacity of the patient. This can be important in patients with congenital heart disease, myocardial diseases, to guide on therapeutic interventions and assess the rehabilitation programs and the patient's capacity to participate in activities. Okay. I'll skip these because they're not arrhythmias. We should know that children are not small adults. There are some differences from pediatric patients from adult exercise testing. There are, as I said, the indications are more diverse. The wide range of patients can be really small and larger ones. So we have more flexible approaches. We need to select an appropriate testing protocol, proper equipment that's age appropriate. Also, children need encouragement and special attention for safety during the testing. They have higher heart rates. my mobile. Yeah. I'm sorry. Okay. Sorry. Okay. ECG changes generally they are quite the same as in adults. In general, the responses to exercise, ECG to exercise, are similar in children and adults. Also, the ST changes that are indicative of ischemia are the same in adults and adopted by the pediatric patients. The testing modality we use for testing, exercise testing, either the treadmill or the bicycle. And bicycle is actually the preferred method. It can be possibly to be used in children more than 5 years and more than 110 centimeters. Protocols used, the standard Bruce protocol or the modified Bruce protocol, that's what we use for the young children. Blood pressure should be monitored at rest and during exercise and recovery, and the ECG to be continued during recovery for the late arrhythmias. There are contraindications to exercise testing, not particularly in children, they are just absolute contraindications. Patients with acute myocarditis or pericarditis, severe outflow tract obstruction, acute myocardial infarction recent, less than 2 days, or unstable angina, pulmonary embolism, acute aortic dissection, very, very serious conditions. If a patient has a decompensated heart failure, patient with symptomatic severe aortic stenosis, if already the patient has severe uncontrolled arrhythmias, has acute infective endocarditis, or active illnesses like acute hepatitis or renal failure, or he has a physical or mental disability, will not make him able to go through the test. Okay. Generally, it's in children. It's not. It's a safe test and can be done. But however, we need to know when to stop the exercise. If we're doing the exercise, ECG in patient is not contraindicated. We need to stop the test. There are absolute indications to stop the exercise testing once there is a drop in the systolic blood pressure, more than 10 millimeters mercury from the baseline, despite increasing the workload, especially لو ده معاه evidence of myocardial ischemia, or if the patient develops significant symptoms during the test, like chest pain, dizziness, dyspnea, or severe fatigue. If he has starts to have dizziness or near syncope, or exhibits signs of poor perfusion, or he develops sustained ventricular or other serious arrhythmias, including the second or third degree heart blocks, or if you have ST elevation, or simply if the patient wishes to stop. Okay, to sum up, exercise testing is a powerful non-invasive tool for diagnosis and management of pediatric arrhythmias. It provides a valuable insight into the relationship between physical activities and arrhythmias, helping to stratify the risk and guide treatment. We need to select a proper protocol, interpretation, and awareness of the pediatric specific factors, which are key to ensuring an accurate diagnosis. And actually هو ليه applications تانية كتير حتى non-cardiac, بس it was not the scope of my talk in children. Thank you.